my general surgery residency in the Philippine General Hospital, 1976 to 1981. This is a talk to inspire aspiring general surgeons as well as a memoir. This was prompted by a request by the 2022 Training Committee of the Department of Surgery of Hospital ng Maynila Medical Center on March 14, 2022, to give an inspirational message to the residents through a narration of my experiences in surgical residency, the trials, and how I managed to cope. This narration may well serve as my short memoir containing slivers of experiences during my general surgery residency in the Philippine General Hospital. First, why did I decide to go into general surgery for my specialty training? After passing the Philippine Board of Medicine in 1975 and serving the mandatory 6 months of rural medical service in Jumalik Island, Quezon Province, I decided to go into a general surgery residency training program starting 1976. My rationalization consisted of the following. My perception was that I could accomplish more tangible results with surgical management than non-surgical management. My thinking was that I could learn the non-surgical management, such as the specialty of internal medicine, by self-study. My stint in the rural medical service in Jumalig Island also prodded me to go for general surgery specialty after I experienced helplessness when I would encounter patients with surgical conditions. Why general surgery? I like its broadest coverage among the surgical specialties in terms of the number of organ affectation that I could treat. During my time, a general surgeon was really a general surgeon, an all-around surgeon, and a jack of all trades who could manage practically all types of surgical conditions, including those in the subspecialties of neurosurgery, urology, thoracic surgery, etc. There was only a few fellowship programs in the subspecialties yet, and we had a good amount of training in the subspecialties. The above were my personal reasons for going into general surgery. I believe nobody can or should question or criticize my reasons, as I am entitled to a freedom of perception and choice. Ask any surgeons why they took up general surgery or any subspecialty for that matter. For sure, there will be different answers, some totally different from mine, and some may have little similarities as mine. Whatever they are, I will not question the reasons. As I said, everybody is entitled to a freedom of perception and choice. You current general surgical residents, I have no doubt you have your own reasons, varied and different from each other. I maintain my position. I will not question your reasons, as you are entitled to a freedom of perception and choice. Note, however, there is an exception to my principle of freedom of perception and choice. There will be a time in which your reasons for going into general surgery will be asked, scrutinized, and weighed as to appropriateness and significance, if not validity. This is the time when one is applying for a general surgery residency position in a hospital, and one is competing with other applicants for an appointment. As I said, your reasons will be asked and scrutinized. Then your reasons will be compared with those of the other applicants. There will be balancing and comparative weighing of reasons in terms of appropriateness and significance, if not validity. This balancing and comparative weighing of reasons for going into a general surgery program among different applicants may have points in the decision for appointment or no acceptance. Outside of the application for general surgery residency setting, as I said, nobody will question your reasons. However, at the end of the day, one should make a self-introspection on whether the reasons are valid or not. The introspection can be done anytime after starting the general surgery residency program, such as in the early stage, first or second year, midway, such as third year, and even at the end, last year, or on graduation day. One is free to adjust the reasons if one sees some flaws in the validity. After adjusting the reasons and after correcting the flaws in validity, one is free to decide whether there was a regret or still no regret in going into general surgery. Probably the flaws in validity are minor. If there is a regret, one is also free to decide whether to quit the program or to finish the program with perseverance and adjustments. Again, there is this freedom of perception and choice. In my case, my introspection during my residency years showed validity in my 3 reasons. I had no regrets whatsoever, and I was determined to complete my residency program with flying colors. With flying colors. When did I start and finish my general surgery residency in the Philippine General Hospital? The answer is July 1976 to June 1981. So this was a 5-year program. What were the memorable experiences that I had? I can categorize it into 2. 1, hardship and challenges, and 2, achievements with flying colors. For the hardship and achievements, general surgery residency training in PGH was not easy, but surmountable. I believe general surgery training in other hospitals was not at that time and will not up to the present time be easy, but it was and will be surmountable as long as one has the discipline and perseverance. During surgery residency in PGH, my hardship and challenges can be categorized into at least the following: workload, patient care, which include patient care, and administrative and clerical tasks. Number 2, presenting in conferences, both sectional and departmental. Study to pass sectional and departmental examinations. Researches, management of consultants, seniors, peers, subordinates, and colleagues in other departments. And the last hardship and challenge is the management of logistical needs in patient care and in training. For the first hardship and challenge, workload. Workload consisted of patient care services, which include patient rounds, patient consultations, operations, and administrative by the senior residents, and clerical tasks by the junior residents. Tremendous was the patient care services that the officially declared 24-hour duty every 3 days could not be implemented as 24 hours, but was stretched to 48 hours or even more. PGH has a 1,000 bed capacity excluding private wards at the time of my training. The Department of Surgery had officially 200 service beds assigned to it, but expandable when the allotted beds were fully occupied. There were 10 operating rooms for major cases and 5 for outpatient cases. The 1980 census, I was there from 1976 to 1981, showed more than 1,000 operations were being done per month, about 480 major operations, and about 520 minor operations. Emergency room consultations was about 3,000 per month. Outpatient consultation was about 1,600 per month in the general clinic and about 1,500 per month in the specialty clinics. The number of residents per year averaged 34, inclusive of the straight residents in the subspecialties. The average number of residents per general surgery service, we had 3 services, GS1, GS2, and GS3. The average number was 5 with from different levels of residents, usually 2 first years, 1 to 2 vice chiefs, and 1 chief. Official 24-hour duty schedule was every 3 days, but oftentimes, as mentioned, duty extended to 48 hours or even more. I personally experienced this workload hardship that I decided to stay in the dorm in PGH for the full 5 years of my residency. I had no time to go home in Quezon City. It was good I was not married yet, no divided attention to wife and children. This workload hardship is still present today, this year, 2022. My son is now on his 4th year general surgery residency in PGH. He is experiencing the same thing. No such thing as the 24-hour duty every 3 days, but 48 hours duty every 3 days in reality. I believe this workload hardship is still present. It's also present in other hospitals. How did I cope with this workload hardship? Perseverance and discipline. Or should I say, discipline, then perseverance in the midst of a resolve to complete the training program so as to become a general surgeon. Beside discipline and perseverance, I looked at the positive side of the workload, particularly on the patient care service. More patients seen and operated on, more training and learning acquired. As to the second hardship and challenge presenting in conferences, both sectional and departmental, no residents would be exempted from presenting in weekly conferences, both sectional and departmental. Sectional conferences would include weekly service census of patients, pre-op and post-op conferences, morbidity and mortality audits, and other conferences like case presentations and case discussions and lectures. Department conferences would include predominantly morbidity and mortality audits, and at times lectures. The challenges that I had with presenting in conferences were these. 1, I had stage fright at the extreme degree. And two, I had the fear of being roasted and humiliated, especially during morbidity and mortality audit conferences. For the stage fright, I mitigated this by doing researches, then orally presenting them in research contests, in surgical forum, residence nights, and Philippine College of Surgeons conventions. Note, these research paper presentations were done during my residency years. I completed 5 research papers with 13 oral presentations. Somehow, I mitigated my stage fright with my frequent oral presentations. But to tell you honestly, I still have it up to this time. For the fear of being roasted and humiliated during morbidity and mortality audit conferences, I mitigated this by being vigilant in my patient care and in my operations, in avoiding morbidities, particularly the glaring ones, and mortalities, particularly the unjustifiable ones. I recall I most likely presented only in around 5 morbidity and mortality conferences. The other ways that I used to mitigate being roasted and humiliated were, number one, presenting the data and information in a clear and concise manner. Number two, explaining fully and honestly the circumstances that led to the morbidities and mortalities. And three, admitting right away the flaws in my management. Third hardship and challenge, study to pass sectional and departmental examinations. We didn't have the residence in training examinations or right that you have today, but we had regular sectional and departmental examinations. I strived my best by studying the Swartz textbook of surgery to pass all the examinations as I wanted to graduate. I succeeded. The fourth hardship and challenge, researches. Researches by residents were required for graduation, but this rule was not strictly enforced. Just the same, I invested time and efforts in doing researches and presenting them as early as 1977 at the end of my first year. I saw the importance of researches in improving my knowledge on a certain topic and in improving my credentials as a surgical resident and after graduation. Again, being aware of the importance, making a resolve, and then implementing the plan with discipline and perseverance were my strategies. I will present my research accomplishment later as one of my achievements with flying colors. The fifth hardship and challenge, dealing with people such as consultants, seniors, peers, subordinates, when you are already seniors, and colleagues in other departments was also a challenge that had to be managed during my residency. This was also true for everybody in the department and also true up to now and will forever be around in any organizations. My strategies in managing this challenge consisted of 1, following rules in the department and hospitals, 2, obeying people in authority and in the upper hierarchy, 3, respecting people at all levels in the hierarchy, 4, being cordial, 5, managing the personality and particularly the consultants and seniors by adjusting to their mindsets and moods. The sixth and the last hardship and challenge, which is management of logistical needs in patient care and in training. In any government hospital, there would be the frequent challenge of lack of logistics, both in patient care and in training. Rarely did I have to spend my money for patient care needs as my salary was only 600 to 700 pesos per month. I resorted to the next available options or alternative in terms of availability of resources in patient management, if I could not innovate to provide or patient cannot afford the first option. I controlled, meaning not done rampantly and done judiciously, the popular practice of Robin Hood style of accumulating and storing needed medical supplies for use by subsequent needy patients. For example, I justified my overprescribing a little of sutures and intravenous fluids by saying that I could not predict exactly how many would be used. I prescribed under a contingency basis. If there were unused prescribed medical supplies, I kept them for use by subsequent needy patients. To support my training needs, however, I saved money from the 600 to 700 pesos per month salary that I was getting to buy a camera to take pictures of surgical specimens and other teaching materials, and also a slide projector. This facilitated my lecturing to medical students and also in my researches. The next category of memorable experience is the achievement with flying colors. I had a resolve from the very start to make the best out of my training to become a well-trained general surgeon. I was competing with myself through discipline and perseverance. I was not competing with my co-residents. Case in point, I did not aspire to be a chief resident. I actually did not like the job. Fortunately, I was not appointed. My two most memorable achievements with flying colors, which I am proud up to this day, were the following: researches, paper presentations, and publications. That's number one. And number two, creation of the Philippine Stoma Association. For the researches, paper presentations, and publication, I was heavily involved in this research paper presentation and publications. As I said, I perceive the importance of researches in improving my knowledge on a certain topic and in improving my credentials as a surgical resident and after graduation. Here are my accomplishments during my residency. I completed 5 research papers. I had a total of 13 oral presentations in the department's surgical forum, Philippine College of Surgeons Residence Nights, Philippine College of Surgeons Conventions, and in the postgraduate course of the PGH Department of Orthopedics on my last year. I had 5 research awards for my 4 papers. I had 6 published papers with 1 published internationally. As to the creation of the Philippine Stoma Association, I was proud to be the person behind the establishment of the Philippine Stoma Association, which was the first colostomy club or support group in the Philippines. When I was rotating in the section of colorectal surgery and when I was still a resident. With this project, I initiated the training of ostomy nurses in the Philippines, the first of its kind in the country, the so-called enterostomal therapists. Also, I had my first international publication, Problems and Rehabilitations of Filipino Stoma Patients. That was the title. That's it. That's my memoir as a general surgical resident in PGH from 1976 to 1981, written, narrated with the objectives to inspire young general surgical residents of the Hospital ng Maynila Medical Center Department of Surgery in 2022. I have shared with you my hardship and challenges, and how I manage them. I have also shared with you my achievements that I was very proud of. I hope I have achieved the objective of the task requested of me by the OMMC Surgery Training Committee with flying colors. And most important, I hope I have inspired you, young general surgical residents of OMMC Surgery. Wishing all of you the best in your journey to become a well-trained general surgeon. Mabuhay!